introduce you to Mubashir in a minute, but before we do that, I think it cannot go without note that we are all entering a different phase of COVID at the moment, and we are seeing the numbers increasing greatly, and with some concern to our area. We know that a few of our metropolitan partners have moved into the middle tier, which is high, and obviously we will be all watching with concern and supporting each other through this time. I think it is worth noting, I was about a week ago, I was on a call with the Secretary of State for Health, Matt Hancock, when before we heard of the new tiering arrangement, when he actually identified Birmingham and the West Midlands area as an area that had singularly kept the messaging very clear, very straightforward, and actually had managed that particularly well. And although we are seeing increases, we are not in the same position as some of our northern areas, and I think that is a credit to the work that's gone on through our departments and through our councils. So I just wanted to note that and say that I think we have done a good job for our residents and for our communities. We obviously will be continuing to work together, but I think the work that's consolidated across the region has really helped on the numbers, because there is no reason why we should not have gone up in the same way, other than the fact that I think the work, the single messaging, has delivered that for our residents. So if I can just say a pat on our backs on behalf of all of us, we do obviously have concerns for the future, but we will weather this storm together. And just on that point, I'm just wondering if there's any other points at the moment. I'm going to move then on to a very pleasant task of welcoming Mubashir Ajaz, who has joined us today. And I'm really delighted, Mubashir, that you've joined us at this time. It's quite a tough time for us, but I know you will help to steer us forward. And I'd like to invite you, Mubashir, to address everyone and tell us a little bit about yourself.
Thank you, Chair. Thank you. And thank you for those words, because I think they're very, very important. And as Ed has noted, we've had a really good response from the WMCA led, with a lot of hard work being done by Sean Russell from our side. So I think it's really important to acknowledge him. And on that note, I mean, I just wanted to introduce myself and say that I'm excited and really thrilled to be taking over as head of Wellbeing and Prevention here. It is a challenging time, as you state, it is indeed for everyone who's going through it nationally. I've experienced the pandemic now in my previous role in North London within the STP, and then for a short while leading on the outbreak control in Luton, and now here. And as we start to look forward to getting past the pandemic, whenever that may be, it is important to start working on our agenda of recovery and prevention, and making sure we are better prepared and potentially prevent any future pandemics. And so with that note, that's the kind of ideas that I have for our portfolio going forward, that I hope I can help move us along that path. My background, just a little bit, is very much in healthcare, over 20 years. Starting from cancer research all the way through academia and into public health. But I'm very much focused on wanting to tackle inequalities, and I think it's very appropriate that everyone else nationally is now focusing on something that we as local government workers are quite well aware of for the past many years. So it's great that there's a lot of national attention on this, and I think we'll try and make sure that we piggyback on that and take our agenda forward. And I'm really, really looking forward to working with each of you on bringing that to the fore. So thank you.
And thank you, Mubashir. Welcome. Delighted to have you with us. And I would absolutely endorse everything you say about Sean. I'm going to embarrass you, Sean. But you have been a fantastic force for us, and your enthusiasm has driven us forward and will continue to do so. So really great that you're leading on the Thrive programme, and will continue to do that as well. So I'm delighted at that. So there's a few remarks coming forward in the chat, which I think are helpful to note. And if I can just move us on to the minutes of the last meeting. Actually, sorry, just before that, I do want to, by way of just noting this, last week, I think it was last week, yes, there is obviously right at the moment across the West Midlands Combined Authority around the financial position in advance of the spending review and the challenges that all councils have faced and the West Midlands Combined Authority have faced through this last period. I have supported the Wellbeing portfolio, and I will continue to do so. The work that we do cuts across so many other portfolios, and the ability for us to change the lives of our communities and our residents is so important. And I think that the work that we do and our team do on behalf of all of us is an important sector to change and to drive forward that change across the area. So we will continue to support the portfolio at quite a financially challenging time. And at this point in time, I have nothing further to advise you about, but I just wanted to bring to your attention that there are some difficult discussions going on throughout the Combined Authority, and we will watch these carefully. So, without further ado, I will move on to the minutes of the last meeting, which you will see on page 126. And I would just like, if I may, if we can have any points of confirmation or agreement, if you could just raise the hand, which you might find in the top corner. Well, in mine it is. It's one of the facilities, and if you can just raise your hand in agreement, I've just done that. And if there are others who would do the same, that would be very helpful. Thank you all very much. And I have had no one who wants to speak on these matters. Thank you. So we will agree the minutes of the last meeting. And Ed, are there any matters arising that you're aware of? I have none myself.
Nothing that isn't otherwise on the agenda, Councillor Seckham.
Thank you very much. Okay. Right, we will move swiftly on. Actually, I'm not sure whether we can move swiftly on to Jodie at the moment. Can we?
Yes, I think we can, Councillor Seckham. Could we invite Jodie to take
excellent.
10 now? Unfortunately, he can only be with us for a short period at the beginning of the meeting. Yeah,
absolutely.
Yes.
Jodie, thank you very much for joining us. Please do join us and present your paper.
Thank you, Councillor, and thank you for moving me up the agenda. It's very much appreciated. So the paper I'm presenting to you is in regards to terms of reference of the Wellbeing Board following the CA Board's adoption of a new assurance framework document. Now, the assurance framework document purpose is set out in 1.2 of the report. I'm just going to touch on one of those elements, which is the final one, which is ensuring that there is alignment between the organisational objectives and the output, something we're referring to as the golden thread. Now, one of the central reasons for us developing and adopting this new assurance framework document is to make sure that all the projects, all the programs, all the bids being made where there is CA involvement properly will deliver the agreed strategic objectives of the region as agreed by the WMCA board. This will mean that we are obviously making sure there are improved standards to make sure that strategic justification is there, developed and considered in our approvals processes for everything that the CA is therefore doing, which will hopefully be a huge improvement moving forward. Now, that single assurance framework document does have implications for all of our thematic boards across the CA, and these are set out in 2.2, and I'll just touch on them. So what we're going to be asking all CA thematic boards to do is to firstly play a key role in developing and approving the relevant portfolio annual business plans. So we've got greater political oversight and external involvement in the development of those, and then obviously greater buy-in to what those annual objectives are going to be across the organisation. To provide oversight of something we're calling the portfolio project pipeline. Now, this is something we're asking for every portfolio to develop. It will be a document that will list every bid, every project in development and every project in delivery relevant to that portfolio. It will also, of course, include information that is involves cross-collaboration of projects where you have a portfolio that obviously is involved in numerous areas of the organisation. This will hopefully again provide further political oversight, an opportunity for further engagement in what's being developed, and the opportunity to question those people leading those projects about whether or not they are meeting those standards that we're now expecting to be set in development and delivery of our projects, particularly, as I said, around the golden thread, meeting our strategic objectives. We're asking all thematic boards to advise on major policy change within their portfolio, as you would expect, which of course is a very useful tool in support of our portfolio leads. And performance managed portfolio project delivery being the last one. And this is where the portfolio pipeline will be particularly useful for those projects that are actually in delivery. So the thematic boards can play an additional role in our process to challenge whether we are actually delivering the strategic objectives we set out to deliver when we started those projects. Moving down further into section 3 of the report, entitled Portfolio Improvements, as well as those SAF core roles I've just mentioned, we have also done some further work to look to develop a more consistent role, purpose and approach to all our thematic boards so that they're all acting and behaving with good governance behaviours, all considering the appropriate information and understand their roles a bit more effectively. And this has led to some suggestions which are outlined in 3.5, particularly around membership of our thematic boards, again, to get that consistent approach across the board. The intent of that, obviously, is to make sure we've got better engagement with all our partners and our stakeholders, etc. And we're really utilising the expertise that's across the region. Going down further, as a result of all those changes, and we have done some engagement, obviously, of course, with the CA board, with overview and scrutiny, with ARAC and with the directorates, particularly Ed's directorate. We've ended up with a suggested terms of reference for the Wellbeing Board in Appendix A that we feel reflects all these various elements. There are two bits I would like to just draw people's attention to in that draft terms of reference, if I can. The first being in purpose. Hopefully you'll view for the same version as me and you'll see the word Wellbeing Plan highlighted in yellow. The reason that's highlighted was to ask you, the Wellbeing Board, whether there were any other key plans or strategies that you felt might need to be included in that purpose. And then moving down further under membership, you'll see under non-voting members, we have any to add. That's a question for you as a board. The other thematic boards in these discussions have given us suggested additional membership that they would like to see included relevant to that portfolio area. And it's a question for you about whether you feel there is anything specific to the wellbeing portfolio that you believe could be a member and play an active role in fulfilling the role of this thematic board. So that's the report before you. If you have any questions about that or anything specifically in regards to the assurance framework, I'm happy to try and answer those as best as I can.
Thank you very much, Jodie. That's really helpful, and I know you've can't be with us too long, but if we can just run through this paper. I've got one hand up in a moment. Karen, I'll bring you in. Much of the paper is really a tidying up exercise so that there is a clear understanding of our functions and how we operate, which I think is fine. Yes. There are one or two things I would ask our members to look at, particularly on the Appendix A and the membership, which we have had the benefit of some outside members, which I think have been really helpful around health and public health, fire and rescue as well. And I would not want to lose the benefit that we have had of those members. So I would ask members just to consider that as well. Karen, can I bring you in, please?
Yeah. Thank you, Izzy, and morning, everyone. Sorry, I was a bit late coming into the meeting. So I just wanted to ask, obviously, with the deliverables, the risk register, is that something that we're going to see at every meeting so that we can assess at every meeting where we're at in terms of all the milestones and, you know, obviously the outcomes and what we're achieving? I'm just thinking in terms of membership, whether there's anything further. I know Sue Ibbotson should be here from public health, but I don't know, have we got public health fully attending every meeting? Because I know it's not always.
Well, I think Ed's nodding, but I'm going to, well, he usually do, but we'll pick up on that afterwards.
Yeah, because it's our public health, you know, from all of our local authorities. Obviously, they've got a lot going on at the moment, but we do need further input from our public health officers.
Yeah, if I could just respond on the milestones item. Yeah, I think the intention is that obviously the relevant wellbeing portfolio pipeline would be a standard included item in your papers, not necessarily for you to go over in particular detail every time, but just so you have constant access to that information, and then you have the ability, yes, and then if there is anything in particular you then want to bring to the a future meeting because of the content of that paper, you can obviously make that request. I believe the intent is also to try and make sure that portfolio pipeline and something called the CA activity register, which is going to be a central document which will cover every portfolio of the CA. So it would include all the information from all portfolios, will be accessible online to everyone on thematic boards and all our boards and committees. So it'll be something you can regularly review at your own pleasure and then raise issues as you see fit relevant to your roles on your thematic boards.
Is that going to be on a RAG rated basis, Jodie? Do you know, so that we can see how we're performing at a glance?
Their work is underway at the moment to see how we're going to make that as presentable as possible and as understandable as possible. Obviously, the RAG rating is one of the easier ways of understanding where we're at, but we're doing some work at the moment just to refine that to make sure it delivers all of the purposes it's been set out to do.
Okay, that's super. Karen, is that
sounds good?
Helpful?
Yeah, that sounds good. Yeah. Thank you. Yeah,
exactly. Thank you. Okay, John Beaumont.
Thank you, Madam Mayor. Mayor, see, I'm back in my borough.
You are.
And I'm addressing the issue of my borough on this body. I was surprised to see the Wellborn terms of the Wellbeing board terms of reference. I have a feeling I've slipped over to this from a scrutiny role to a board which has some executive power and is closer to the action that the West Midlands Combined Authority will be carrying through. And I'm, again, just like yourself, I think adding non-constituent members who can't be voting members of the board would be, as a first base, an excellent idea. And I would also bid for the Neaton and Bedworth Borough Council to represent Warwickshire in this regard as well. So there's two bids there, one of course conditional on the other. But I do think this looks to me like a board which performs actions and does not just scrutinise. So I'd be quite interested in Nuneaton and Bedworth Borough Council having a presence on this board. Thank you.
Thank you very much, John. Jodie, any comment back to John?
Yeah, I mean, briefly, like on the purpose of the sort of thematic board. So obviously the name being in the title, they're there to support the theme. That other theme being that portfolio, and that obviously involves a sort of cross of various different governance behaviours, touching obviously on slight scrutiny behaviours, performance management behaviours, hopefully massively on policy development, those discussions about how to develop that portfolio moving forward, and significantly looking to support our portfolio leads. That's something we're really looking to drive through all our thematic boards, that they're all playing an active role in supporting that portfolio lead.
Thanks very much. Ed, I've got you, and then I've got Guy Daly, representing universities as well.
Do you want Guy to go first, and I'll respond to him?
Ed first. Shall I do that? Yeah. Okay. I'll do that way round then. Guy.
Thank you. Morning, Izzy. Morning, Chair, and colleagues. Yeah. So I think a couple of things. One might be self-serving in terms of our sector. So I apologise in advance for doing that. But before I come on to that one, I think it is always important to refresh purpose and membership. So I think that's most welcome. I do think that one should have public health here. Absolutely, and they're obviously such colleagues are busy doing other things at the moment. The other is the sort of system leaders as far as the NHS health and social care system, so STP, ICS leads, etc. And whilst I think if one did a attendance record, then on occasion some of the attendance there has not been maybe what it might be. I think in part that then leads one to maybe have a bit of self-reflection in terms of ensuring that the business of this board is of such import, as it were, that STP leads, etc., are fighting at the door to get in rather than sending their apologies or whatever. I think because of the importance of this agenda, I do think that having representatives from the LEPs in terms of the place of work and economic development, etc., its impact on well-being, I think that is very much a welcome suggestion. And then lastly, apologies for the self-serving stuff, but I would hope that you and colleagues do feel that having the West Midlands universities represented round the table, not in terms of individuals, but just in terms of a sector, has been helpful and would be in the future. I think we as a sector have played a part in terms of contribution, in terms of the work around physical activity that Simon has done, and mental health in the workplace and so on. And I think recently we've been contributing in some small way to the regional health impact work that Ed and colleagues have been doing. So, and I think being, if you like, closer and invited inside the tent helps those things happen to a greater extent. But obviously always respect that a body such as this should review its membership. I'll stop there, Chair.
Absolutely, Guy. I think the value that you, as the sector, have been able to bring is vitally important and will be in the future. I mean, a lot of what we do is developing potential progress to go forward, and I think that the help that the university sector can bring is enormous, and we share that value. Ed, I'm going to drop you once more. I've got Paul Moback as well. Paul, would you like to come in, and then I'll go back to Ed?
Yes, thank you, Chair. I just want to echo Guy's comments really, and to say that I think increasingly our agendas as STPs is aligning with this agenda. It's particularly as we find our way out of the pandemic. Inequalities in health have been significantly exacerbated by the circumstances we find ourselves in at the moment. And so it's going to be a major priority for all of us. And I think the more that we can collaborate with each other, the better, really, to be honest. So I would welcome the opportunity to continue to engage with this board.
Oh, that's fantastic. Thank you for that. Ed, back to you.
Yes, so simply to say, Chair, that we would normally include the STPs, NHSE, PHE, the universities, the Office of the Police and Crime Commissioner and the West Midlands Fire Service as non-voting reps. And I would propose that we continue to keep that list, if you like, as non-voting reps on this board, Jodie, if we can do that. And it already stipulates that non-constituent members are included as voting members, 1 per county as well. So that's provided for already. So I think that takes in many people's comments. I did want to just respond to Councillor Grimstall's comments about the delivery plan. At the moment, our activity is guided by the annual plan, which has a set of high-level deliverables within it. But each year we are in the process of refreshing those, and we will be refreshing those with a wellbeing delivery plan as Mubashir gets his feet under the table, and especially as our work on the regional health impact of COVID, which we're about to present on, starts to come to fruition, because my sense is that that will be the driving force behind our next set of high-level deliverables and our delivery plan, and we will be then reporting back to the board on those things.
Yeah, and you've jotted down that list in the chat facility as well, Ed. So I think that's been a very helpful discussion, and I hope, Jodie, that's given you our thinking on your list of membership, and also on the wider valuing our purpose and also looking at how we perform against our targets as well. Is that what you wanted us to say? Have we missed any points?
No, that was incredibly valuable debate. All notes on membership have been taken on board and will obviously be included moving forward, as of the points around the role of the board. So very, very grateful to that discussion.
Fantastic. Thank you very much. And we can move forward then on that basis. Thank you, Jodie. Right. So having moved that item forward to let Jodie get away, I'd like to go back to the regional health impacts of COVID. Ed, this is going to be you and Lena. Have we got Lena? Yes.
Yes, that's right. Thanks, Councillor Seckham. So I'm going to share my screen, but just to draw your attention, first of all, to the recommendations for the Wellbeing Board. Firstly, we want you to generally consider the presentation that I'm about to share and offer any feedback on this. Secondly, to encourage you to support us in gaining commitments to action from key partners, which I'll explain a little bit more in a moment. And thirdly, to consider what recommendations we might want to make to government in relation to this. And we are proposing to produce a report, but that will become clear in a moment. So forgive me whilst I just find the appropriate file to share.
Yeah. And of course, whilst you're doing that, this was a piece of work that we started back in the summer. So be really useful to see where you've got to.
Indeed. So hopefully that's opening now. Lovely. And we will share this slide set with everybody afterwards. I think it's important to say that, as you might expect, there are political sensitivities around this, so it's why we don't want to share very early versions of the draft report. But we are happy to share this slide set, and we will share a draft of the report in due course with the board. We're calling it the health of the region because originally that was and it is the nature of the report that we're producing. If I move forward, so many of you will remember from last time that we established the regional health impact of COVID-19 task and finish work as part of community recovery work in June 2020. The representatives on the task and finish group are from the combined authority, PHE, local authorities, NHS, universities and the voluntary and community sector. And we published an interim report in August 2020, and there's a picture of that here. We also issued a call for evidence, and I'm very grateful to those that supplied evidence for what is now coming together in the final report that I'm about to share with you. We see the Health of the Region report that we're now pulling together as a counterpart to the West Midlands State of the Region report that was published last month. We also feel that it needs to be a call to action for everybody to actually start working together to address long-standing inequalities in the West Midlands, and that the document itself might represent something of a collective commitment to achieving really positive change in our region. And I'm going to be blunt about it and say, at the moment, I don't see that there is sufficient collective activity on tackling long-standing inequalities, health inequalities in our region. There's a lot of piecemeal activity, and there's a lot of other activity which is not preventative, but at the moment we think that there does need to be something of a call for action, particularly given what we've seen in light of COVID-19. And so to spell that out, why is this important, and why would the WMCA be concerned around these issues? Well, I think that COVID-19 has exposed just how profound the health inequalities are in the West Midlands, and in a moment Lena will take you through some data which shows that. However, it does create a once-in-a-lifetime opportunity to actually start focusing a lot more on tackling health inequalities. And when I say tackling health inequalities, what I mean is, yes, we have to look at individual health-related behaviours, but we've got to understand the causes of the causes, the social, cultural, economic and environmental contexts that actually very often affect health-related behaviours, rather than just tackling the behaviours themselves. And so for that reason, the interdependence between health and wealth is actually a core theme, and the WMCA clearly sits right at the heart of that, in conjunction with health partners in addressing these issues. And I think the crucial thing here is to say that if we're going to build a more resilient region, a region that will be resilient to future pandemics and shocks, then we have got to get this right, because this time round it would appear, if we look at the sheer number of deaths in the region due to COVID-19, let alone the communities who are most affected, we haven't got it right. And so we've really got to put it right for the future. And just to quote Sir Michael Marmot, we address structural racism today, right now. We don't say, oh, well, let's put it off and while we deal with the crisis. No, we have to do it right now, because it's causing the problems right now. And I thought that was a particularly powerful quote from him. So I'm going to hand over to Lena at this point, who's going to whiz us through all of the data and the material that we have gathered. So Lena, over to you.
Okay, thanks, Ed. Just to give a summary of the underlying health inequalities in terms of life expectancy and healthy life expectancy for men and women in the combined authority. Now, life expectancy is on average shorter in the West Midlands than the national average, and our residents also spend more years in poor health than on average. Women in the combined authority spend on average the last 22 years of their life in poor health, and for men that's 18 years. And the causes of this are multifaceted, but some of the main causes of so any death before the age of 75 is considered a premature death. And it's considered preventable if there's something that could be done to reduce the risk earlier on. And as we can see from the charts, rates of deaths from cancer, cardiovascular disease, liver disease, respiratory disease, alcohol mortality, related mortality are all significantly higher in the West Midlands Combined Authority than for England overall. And we also have above average rates of infant mortality. Rates of drug-related deaths are actually similar to the national average, but that actually masks the fact that actually this is an issue that does cause quite profound social consequences and has a wider reaching impact, much like suicide. So looking at the things that cause those preventable deaths, well, the first stage of that is looking at the health behaviours and the risk factors. Smoking is actually, the prevalence of smoking is now relatively low compared to what it used to be. I mean, it's still around sort of 14–15% of the population. But actually, this is one of the biggest causes of health inequalities, because people who are in the most deprived areas are significantly more likely to be smokers compared to those in the most affluent areas. Rates of adult obesity and child obesity are also high in the region compared to the national average, as are levels of physical activity and eligible adults who fail to attend screening for breast cancer. Now, thinking about the impact that this has over the life course, now I think it's particularly important to look at this over a life course for the reason that cumulative disadvantage over the life course leads to poorer health outcomes throughout. So if children have a less positive start in life, that has a knock-on effect on their educational outcomes, on their physical activity levels, on their health behaviours, and later on their employment, and then their outcomes in later life. So actually, disadvantage at the start of life actually has a knock-on effect throughout the life course, meaning that people then die earlier and die in poorer health. So we talked about some of those behavioural issues, but what we don't want to do is focus just on those individual behaviours, because it's well known that focusing just on individual behaviours doesn't work. And the reason for that is because we have to look at those underlying structural causes of the causes. And I'm sure many of you will already be well familiar with this this diagram by Dalgren and Whitehead, which shows the white social and wider determinants of health. To put it bluntly, the conditions of many people's lives in the Combined Authority are hard, and often those unhealthy behaviours that we see are often coping mechanisms for people who live in very challenging environments or circumstances, and often they want to make those positive changes, but they're not really in the conditions that make it easy to do so, and they actually feel powerless to make those positive changes. So thinking about some of those causes of the causes. Now, this is by no means an exhaustive list, but what we've done is we've pulled out some of the key issues in the region. So we know that adults in the West Midlands Combined Authority with a learning disability and those who are in contact with secondary mental health services are significantly less likely to be in stable and appropriate accommodation, and they're also significantly less likely to be employed. Now, in terms of income, I mean, this is actually, by the way, the picture across, it reflects the national picture, but actually it's worth saying the national stats are also pretty shocking. Income, significantly more children in the Combined Authority are in low income families compared to the national average, and in many areas this corresponds to increased rates of fuel poverty and a household income that is lower than the national average. And thinking about the kinds of neighbourhoods people live in, and the food environment is one thing that's crucial regarding obesity levels. Places like Birmingham and Sandwell have a much higher rate of fast food outlets per 1,000 population compared with the national average. So you can see how those environments are shaping people's opportunities and behaviours. So moving on to the impacts of COVID-19. So in line with national findings, it's exposed and exacerbated existing health inequalities, particularly those facing BAME groups, which we'll talk a bit more about in a moment. And this is due to both direct impacts of contracting the infection and also the indirect impacts of the control measures that have been imposed, which have resulted in economic shock. To summarise, those living in deprived areas, people from Black, Asian and minority ethnic groups, and those with additional challenges such as disability, being homeless, having no recourse to public funds or being victims of violence, are at disproportionate risk of both transmission and impacts of economic shock. And those who are employed in key sectors have particularly high transmission risk and employment instability. They're often some of the people in the lowest paid employment, and this actually has particular bearing on BAME inequalities. Now, the pathways are very complex and multifaceted, and we try to talk about them a bit more in the report, but it's worth noting the fundamental link between health and wealth is absolutely apparent, and ultimately where people are already marginalised and excluded, they're likely to be left further behind as we respond to and recover from COVID-19 unless we take steps to actively improve this. So just a couple of key West Midlands insights that we've drawn out. One of the absolutely important things to note is that there is a much higher likeliness of death from COVID-19 in Black and Asian communities compared to the white population. The risk is 4 times higher in the Black community and 3.5 times higher in the Pakistani and Bangladeshi communities. For South Asian patients, there are higher admission rates and higher levels of mortality. There are increased levels of anxiety, both nationally and regionally, as a result of COVID. There have been lower physical activity levels for some groups during lockdown. So some people have reported being able to participate more in physical activity, but actually some groups have found that it's been a lot worse. And actually 40% of women are doing less exercise than they were, partly due to having the increased burden of childcare. And 11% of children are doing no physical activity. More women than men report worsening health conditions, which is also as an indicator of some of the disproportionate impacts on women. So one of the key themes that we're drawing out in the report is the structural inequalities facing BAME communities. And I just wanted to highlight some key observations from the West Midlands inquiry into COVID-19 fatalities in BAME communities. And these included being worried about inequitable treatment that might be received in the NHS. So that was a deterrent to people asking for help quickly enough. Many people experienced an NHS and care system that was overwhelmed. They felt there was poor communication of public messages about symptoms, both that were communicated by government to BAME communities. The voice of the community had simply not been heard in the way health services were designed or delivered. And also there had been disruptions to traditions and processes for grieving, which had created significant mental health risks. It was felt that many of the groups that worked with people with long-term health conditions had been underfunded, and many frontline workers of BAME ethnicity groups had had direct experience of inadequate provision of PPE, which links to the increased risk. And there isn't really adequate data to track the impact of the pandemic according to ethnicity. One of the examples is ethnicity recording on death certificates, which would make it more helpful to track those impacts. And ultimately, a clear strategy for understanding the scientific evidence for the disproportionate impact of COVID-19 on the BAME community had not been communicated effectively. And there was low confidence, in fact, pretty much low to non-existent confidence that lessons would be learned and there would be positive change, which I think is probably one of the most important things to come out of that, actually. There's low confidence. So thinking about opportunities for change. The underlying principle here is to take a radical prevention approach, which is about sort of challenging the traditional. So rather than returning to the old normal, it's using learning from the pandemic to try to reach a new normal where we take into account the social, environmental, political, economic and cultural factors that impact on our health and well-being in order to reduce avoidable gaps in life expectancy and healthy life expectancy between the most and least advantaged. And a key fundamental concept of that with that is that of inclusive economies and inclusive growth. So just to make the distinction, inclusive growth is economic growth that actively seeks to reduce inequalities and considers what's important to our citizens. But that has to take place in the broader context of an inclusive economy, where we challenge the economic status quo and actively seek to reduce existing inequalities in areas where there isn't a focus on economic growth at present. So it's actually making a change for everyone. And one of the other principles is on place-based working, because that takes into account the unique demographics, assets and needs of our populations, and looks at the relationships between civic level organisations, communities and services in our engagement processes, and where we look to be making changes to practice.
Thanks, Lena. That's absolutely fantastic. So that's our analysis. And I just want to now spend the last couple of minutes talking about action and what we're actually going to do about these issues, because I think our concern from the outset has been that, yes, it's been important to understand both the underlying health inequalities facing our region and also the ways in which they have been exposed and exacerbated, particularly with BAME communities through the COVID crisis. But unless we're prepared to take action to do something about it, then it will just be another clever report that goes on a shelf. So what we are setting out here is a framework for action around 4 areas that are all interrelated. First and foremost, we have to take action in relation to improving outcomes for people from ethnic minorities. That has to be at the forefront of our focus. However, it is important that we enable people themselves to take responsibility and to be able to drive forward their own health improvement through what we're calling enabling people-powered health. But that in turn has got to also feed into the sense that there is widening access to health and care services. But fundamentally, underpinning all of this, and again, the diagram it's very difficult to present a diagram. Underpinning all of this needs to be an approach which tackles those wider segments of health that we've talked about so much so far in the presentation. So those are the 4 areas of action in our action framework. Now, what we're setting out to do here is to ask everybody, and I'm talking to all the people on this meeting now, and indeed others, to make commitments to action, so that this report is not just the WMCA's clever thinking, but actually a whole set of commitments that we all make to actually tackling some of these problems, commitments that we can make literally in the next couple of weeks, so that we all set ourselves on a journey. And so the Combined Authority has set out, as you can see here, 12 commitments. You'll see we're still in draft, and so these are things that we might adapt and develop over the next couple of weeks as we finalise the report. But things like our commitment to doing detailed equality impact assessments of all of the directorates, housing, skills, transport, and so on in the Combined Authority. Having a targeted Thrive mental health programme, which we co-design with BAME communities and employers and employees. And we're talking to our Leadership Commission about whether they think there are other commitments that the Combined Authority should make. I'm not going to go through all of these because it will take some time, but I do want to come across to this one on the right-hand side, around incorporating a health in all policies approach into the existing inclusive growth framework that we've got. Again, putting health more firmly in terms of the work that we're doing in the Combined Authority. So there's a set of commitments from the Combined Authority, but also, as many of you will know, we've been writing to you, phoning you, contacting you in various ways to ask you all to make commitments as well. In each of these 4 areas. The deadline for having commitments to us is next Wednesday. It's the absolute deadline. I hope that many of you are going to pass on those commitments to us by the end of play today. I know some people are working on that already. We've identified 15 key partners, and we're really hoping that each of you will make some commitments yourselves. It doesn't need to be 12 each, don't misunderstand me. 3 or 4 would be absolutely fantastic. And we've approached another 20 organisations that we think also ought to be making some kind of commitment in each of these different areas. So, and there's some prompts here in the grey boxes as to the kind of things that you might want to consider in relation to commitments to action. And we've got some examples already. In terms of improving outcomes for ethnic minorities, Dudley Local Authority did a fantastic outbreak management plan with their Roma community. Jumping down, the Black Country Mental Health Trust have appointed BAME coordinators, and the NIHR Clinical Research West Midlands Network have started to develop a particular focus on BAME data. Those are some examples. Coventry, for example, have declared themselves a Marmot City. There's a Solihull inequalities strategy. Even things like the University of Birmingham's Clean Air Initiative is another good example of the kind of commitment that could be made in relation to tackling the wider determinants of health. So lots of things that are starting to come through. We're really hoping that over the next couple of days, we will be able to come up with a list of, I don't know, let's be ambitious, 100 things that different partners across the region are doing in order to, or committing to do, in order to address the issues that we are most concerned about. And then we've got a set of recommendations to government, and goodness me, how much more compelling these recommendations to government would be if we can go to government and say, well, here's the 100 things that we're doing, what are you doing? I will just touch on some of these. We think that the work that Kemi Badenoch is doing needs to come through into, again, a clear government action plan around improving outcomes for ethnic minorities. We think that government should commission more research and data and analytical work around the impact of COVID and more broadly the reasons for race disparities in health. We think that the government could invest more in a radical health prevention fund, something that we've put in our comprehensive spending review proposal for the West Midlands. And we think that some of the ideas in the recent Kruger report on community right to serve, where communities can take a better role, play more of a role in relation to health and social care provision, ought to be piloted here in the West Midlands. In terms of widening access, we think the government should move forward with plans to fund digital screening hubs in high footfall locations in the West Midlands, so we can catch up on that backlog that we've got around screening. And we haven't got formal recommendations yet, but we think there's certainly something about primary care in deprived neighbourhoods, how we invest in that properly, and also in tackling digital inclusion as well. And then finally, in terms of tackling the wider determinants of health, apparently there's going to be a new NHS phase 4 letter on COVID-19, and we think that tackling health inequality should actually be the main focus of that letter. We think it should be health and wellbeing outcomes should be much more written into the work that BAYS does, particularly around economic development policies. For example, around industrial strategy, which apparently they're refreshing at the moment. And we think that in very crude terms, the government should double the proportion of health and social care spending spent on prevention at the moment, which is currently only 5%, and push that up to 10%. So there's a set of recommendations to government there. The last slide is simply to say, in terms of our next steps, we're presenting these slides to you now for discussion. We're looking forward to receiving more commitments to action in the next few days. There'll be further consultation with a number of other groups on a full draft of the report later on next week. The deadline for feedback on the full draft of the report will be the 26th of October. And then there will be a designed draft that's pulled together. That will then go to the Combined Authority Board, sent out on the 4th of November for the discussion on the 13th. The other thing just to flag is that we're also looking to pull together some kind of animation or short video that will accompany the report, so that we hope a wider number of people will be able to engage with what we're wanting to say. I'll stop there, Councillor Seckham, but I hope that's okay.
Yeah. Brilliant, Ed, and Lena, thank you so much. What a fantastic report, and how exciting we have some real opportunities. And I think there'll be some evidence in there that probably comes as no surprise to us, but it's what we do with that. And we talked about this at the last combined authority, about the importance that this shouldn't be a document that just sits on a shelf and collects dust again. And Lena, it struck me the comment that you made towards the end of your presentation, which was about the confidence by our residents, by our people, and the people of the ethnic community, that actually we're going to do something. You know, what is the point in doing this if we do not intend to do something? So I'll open up the discussion, and Wayne, you're the first in with the hands up. Thank you.
Thanks, Cheers. Morning, members. Certainly just a couple of comments from me from a fire service perspective. Firstly, really insightful and detailed, fantastic presentation, Ed and Lena, so thank you very much for that. For those that don't know, and the members that don't know, the fire service are currently out for consultation in terms of our integrated risk management plan, which is our strategic plan for the next 3 years. One of the areas that we're looking at in terms of how we approach that is obviously wellbeing. Interesting and really insightful, Ed, that we likewise are using with causes, and obviously in terms of our service and what the public need from us, that's obviously something that's going to be integral in that going forward. So firstly, a request, really look forward to being able to receive this presentation, Ed and Lena. I thought it was really good, and certainly will assist us as part of our sort of strategic planning going forward. But likewise, obviously really interested in the link and the impact of COVID on underrepresented groups within the West Mids. We all know what a diverse area the West Mids is. So obviously for us and our planning going forward, the work that Ed and the team are doing in the WMCA in terms of looking at that for our future sort of strategy and growth will be absolutely fantastic. So as a service, thank you. Be really, as I said, looking forward to receiving the presentation, and likewise keen to play an active part in ensuring that we consider the impact of COVID and the impact on social inequality and race, religion, etc. on the community. So thank you very much for that.
Yeah, Wayne, that's really helpful, and I bet if you overlaid some of your causes for fires and all the rest of it, we would start seeing a pattern that we would recognise as well. Yeah, really insightful, I think. Thank you. Les, you're next.
Yes, thanks, Chairman. This is obviously based very much on the West Midlands, but I can certainly see everything that overlays with what we're doing in Warwickshire. And it'd be good to overlay Warwickshire on top of the life course and something like that, which I can do. But just things that we're already doing. I took through cabinet in September a total review of our BAME community and all the effects, everything that's listed in this document, and we've given that a two-year life, and Public Health are doing that. We've also set up a members working group to support it, and it's in our council recovery plan. And coincidentally, through cabinet last week, we took our new Gypsy and Traveller policy and strategy, which totally links back into what you've shown us today. So happy to cooperate and work across the piece with this and overlay what we're doing on top. So thank you. Good document.
Yeah, really good. And yes, we need to quantify that for you, Ed, I think. And it does occur to me that the best things that we could do for residents and help them to lift their opportunities in life are around housing, jobs, education and skills. And one of the things I've often said is the best thing you can give your resident is a good job, and help them to help themselves and their family. But they need that help, and that's what's so important in it. Paul, you'd like to come in?
Thank you. I just one of the conversations that we're currently having within health, and certainly we're petitioning within with NHS IE at the moment, is that there are communities like ours that have been far more differentially hit by the pandemic than others, and therefore You know, we're petitioning at the moment, basically, for as we go through the next kind of spending review within health, how can we have prioritised resources within our systems, but, you know, particularly to support this agenda? And I mean, it may not be appropriate, but I'm just wondering, is there, in terms of the asks up to government, is there something along those lines that we should be making, you know, because our population, along with the conurbations like Manchester and Liverpool that we're seeing now, you know, ours was more significant, as you know, in the first wave, but should we be petitioning for disproportionate support to the issues that we're identifying in this report?
Well, I think that would, you know, that partnership would be good, wouldn't it? It would help one. Sorry, who was that coming in?
It was Ed. I just wanted to respond to Paul, if I may.
Yeah, fantastic.
I mean, Paul, yes, absolutely. And if we wanted to sort of sit down and kind of curate those recommendations, we'd be absolutely delighted to do that with you. Yeah. I think, though, that asking for additional resource from government is all the more compelling, as I've said in the presentation, if we're showing what we're already doing with the existing resources we've got. So I would suggest that, you know, if we can identify you know, a set of commitments to action from your STP and the other STPs, which show what we're doing already, then that will give greater weight to whatever recommendation we want to make in terms of additional resource.
I think that's a fair point. And one of the things, I know it's a bit late in the day, but one of the things I was going to suggest is that NHS England locally have set up what health inequalities, well, they've called it a star board. And Danielle Oom, who's the chair of Walsall Healthcare Trust, is chairing that. I think we should connect with her, you know, today, just to get her views on what commitments could be made to come in this, if she hasn't done that already.
It's absolutely not too late.
That's great.
Okay, I'll speak to her today then about that.
Let's do that. That would be fantastic. It'd be very interesting too to overlay the access to health with our particular BAME or super output areas as well, to sort of see if we're actually delivering against those particular groups. That'd be quite interesting. Yeah. Rebecca.
So hello everyone.
Rebecca Farm.
Yeah, so I'm from NHSEI, and I guess I just want to build on the comments Paul made, and also one of the prompts in Ed's presentation around the phase 4 letter. So within the phase 3 planning letter that we sent, that the NHS got, they were required to do plans for restoration recovery specific on health inequalities, and that sets out kind of, there's 8 criteria and there's a set of commitments in there, and it feels like there's quite a practical thing that we can share those kind of STP by STP, and that will actually give a very concrete set of commitments. And for example, that covers some of the issues around digital inclusion as a factor, around having better data around the BAME impact, and a range of other things that correlate with a lot of what was in the presentation. So I think it's probably it's fruitful to join the dots, for want of a better word.
Fantastic.
We've been trying very hard, Rebecca, but I'm absolutely delighted to hear that you might be able to provide those, because we've been trying to get them for a couple of weeks.
Lovely. Let's build on the enthusiasm that this report has brought forward. Please do read the chat box, because there's some really enthusiastic and helpful comments that are coming through there, and you know, some of these we need to follow up on. I would very much welcome as well. I have no other comments. I think we've covered the points that you wanted, Ed, haven't we? Is there anything we have missed?
I think Councillor Grinstow wants to say something.
Oh, does she? Ah, sorry, Karen. Please do come in.
That's okay, thanks. You mentioned Solihull in there in the inequality strategy, health inequality strategy that we've developed. We've actually got a new member of staff within our public health department, Rob, and his surname escapes me. He's new, but I think he's known to the combined authority. So we are dedicating. Davis, that's it. We are dedicating staff, to this, because we know it is so important at the moment. So are you asking for us to feed in all of the work that we do, because I can tell you we've got a new draft walking and cycling strategy coming to cabinet member, I think next week or the week after. So I'm just wondering how we feed in. So we're talking about joining the dots, so making sure that the CA strategy and local authority strategy meet, and that we're all doing the right things. What else did I want to say? Obviously, we're following the life course in terms of our health and wellbeing strategies, fitting in with the STPs, all of that. It does strike me, when we're talking to government, we're all talking to government at the moment, but it's something quite simple that started, and I think I may have spoken about it before. When we went into lockdown to start with, the instruction was everybody gets an hour's exercise every day. That has sort of disappeared, and it's almost like if that was still there, more people would be just taking that hour's exercise, and that would benefit their mental health, their physical health, everything. So some people are quite good at following instructions, so it's just, can we get that in there somewhere to say keep doing that hour's exercise? I think it's a good point.
I think it's a very good point. It has lost its impact from the initial. I have to say, can I emphasize in? It's an absolute luxury. We are descending into yet more and more meetings, and they start earlier and they end later, and it's you just bounce from one to the other. So I am one of those 40% of women who are not getting my hour's exercise a day, and it's just the pressure of what's going on. So I think we have to have a work-life balance better, and
we're losing it, aren't we?
These poor women, we are losing it, and these poor women who are also trying to fit childcare and managing that into it. It is really difficult, but when we have lost the message around how valuable this is and how important. So I'm slightly conscious of the time, so I've got who have I got now? Sorry, just going back to it. Here we go. Karen, that's your hand, isn't it? Don't worry, I'll So really important report, one that has generated a degree of enthusiasm, which I think is so welcome. Something that all of us want to reflect, our society, our communities that we're shaping, and trying to shift the dial and make the West Midlands an area that really is addressing those health inequalities would be an outcome in itself that I think would be the best thing that we could ever deliver for our residents and our communities. Ed, are you happy that we've covered everything that you wanted us to cover? And the only other thing I would say is, can you send every one of us a letter to ask us to feed into your commitments, just in case people forget?
We have, but yes, we will reinforce
you
that.
have.
We'll reinforce that, and just to say thank you very much to everybody on the meeting today for those commitments that people have made. We'll follow that up immediately. Thank you.
Fantastic. Well, a great report. Thank you both so much. Will we have this report back in sort of 3-4 months' time, just to sort of see the next progression?
It will go to the Combined Authority full board in the middle of November, but yes, I'm intending that we build something of an action plan on the back of this. But just to be really clear, because I think Councillor Grinsell asked a really important question earlier, this is what I want. I want this document to be a shared thing that is celebrating the wonderful work that the different parts of the health ecosystem are doing in many respects already, and plan to do in the future, and something that can really give our region some hope that we are pulling together in the right direction. What the Combined Authorities role is on the back of this, I think, still requires further discussion. I think that's the kind of conversation that we need to have at our next meeting. But to be 100% clear, this is not the Combined Authority planning to do lots of different things. This is a shared commitment where the commitments to action will be taken by all of the different partners in the region, and the combined authority will have a relatively limited role in kind of coordinating and galvanizing things.
Absolutely, but we can develop an action plan where everyone has a part to play, which would be very helpful. Lovely. Thank you all very much for that, and I think we all of us will look forward to seeing this progress and develop, and see the results and the ticks that we can achieve on it. Be fantastic. May I then move us on? The next two reports we've got are we don't have papers for them, so there's one. The first one is on preparedness. Rebecca, I think this is you.
Yes, and I think what I'm going to do is just do a quick verbal update on what we're doing to prepare for wave 2 COVID. Is that what you're hoping for? Okay, yeah. Lovely.
Yes, I think that's right. Yeah.
So I was going to just set out the kind of approach we've taken, and then the kind of key points to advise on response and resilience. So just to say, in terms of the approach, all systems were sent a phase 3 letter around restoration and recovery, and to present plans to us based on an R=1 COVID rate or transmission rate, and those plans were submitted in September and to cover the period September until March, and that was with clear trajectories to recover service levels to the pre-COVID baseline. So that's one little bit of context. And then further, we've done a wave 2 readiness assessment, which has taken place at the end of September, and that's to understand the actions to kind of manage and mitigate the impact of an increase in cases, and including what the system level surge or escalation response will be if there's a more intense peak of COVID going forward. And secondly, how COVID demand could impact on the restoration of the services and the commitments in the phase 3 plan, if that makes sense. As part of that process, we requested modelling and an assessment of the impact of COVID rates of circa 5%, 20% and also 35%. So that's the kind of approach adopted. Now going to go into the kind of key conclusions from that. So overall, there will be an impact, particularly on the restoration of elective services across health, if there's a sustained increase in COVID cases, and we're already seeing some of this. I note in terms of the media what we're seeing in Birmingham, for example, in terms of both elective care and also urgent care, and I know you'll be aware of that. Some of the key actions that are being taken within systems and organisations to protect services include the prioritisation of green sites, and again an example kind of close to home is the Solihull Hospital, obviously is doing pure kind of COVID-free elective work, and also pathways within hospitals. There continues to be very high utilisation of the independent sector to safeguard kind of clinically urgent cases, and that has been very well used across the region and will continue to be so. There's very robust clinical prioritisation taking place across all organisations, and actually we are reasonably well assured, even with the scenarios on COVID, that, for example, the cancer services will be largely protected, and obviously that is really critical in terms of kind of urgency and patients being seen. There are plans in place for cross-organisational mutual aid within systems. These are very well developed, particularly on critical care, and obviously the usage of critical care was a key feature of the wave 1, and there's lessons learned on the back of that, and there is much more resilience and robust capacity plans in place, and well-established critical care network to move patients if there's peaks kind of above capacity within organisations. The Nightingale Hospital is not open at the moment, but it is still available and is there as a regional facility to decompress hospitals which are within an hour's drive of the facility. And then just particularly on the kind of urgent care and thinking about winter, nationally we're implementing a 111 first, so a much more robust 111 service that will hopefully enable less patients to be coming into hospital and more access to different levels of treatment. And that's certainly coming in by, well, the intention is 1st of December. There may be some delays and things, but that's being implemented to support the kind of post-Christmas winter period. And then I'll just make 2 more kind of key points and kind of perhaps referring to some of the earlier conversations. Staff wellbeing is a huge risk and is also critical to the NHS response. And so there is significant work ongoing across all organisations and across systems to support that. That includes robust and high quality BAME risk assessments and the response to that, and including redeployment, greater recruitment, and also significant support going in to support wellbeing. And we've seen a number of our mental health providers step up and organise kind of cross-system support to other organisations to really help with that. But that said, it still remains a challenge, and I know you'll recognise that. And then finally, the flu vaccination programme. We've got plans for all systems which have been peer reviewed, very robust, and which focus on inequalities and certainty around the distribution of the supply and how that's accessed. So we're reasonably confident around that. Probably also worth saying is we're at planning phase for COVID vaccinations. So whilst there's no certainty as to a go live date, clearly it's important that we've got the infrastructure and are mobilising so we're ready if it becomes available. And as I say, that's at kind of planning phase. So I'll pause for breath there and see if there's any kind of key questions on what I've said or indeed what I've not said.
Thank you very much, Rebecca. A really helpful and full report. And I've got Paulette somewhere. Paulette, please do come in. Yeah, yes, finding the mute button. It's always a challenge.
Good morning, Izzy. I've said good morning already, Izzy. Good morning, Rebecca.
Yeah,
thanks for that fantastic report. The question, moving into this second challenge, re-COVID, the questions I'd like to ask are, you talked about the Nightingale Hospital and the fact that it's not opened at the moment. How often is that being reassessed? That's my first question. And you talked about the flu vaccinations, the fact that at the moment there doesn't seem to be a problem with supplies and what have you. What have we done towards the comms of this so that we get the actual uptake that we need going forward? Because with everything that's happened in Birmingham, and I'm sure everybody knows we've had a few incidents, I'm getting some twitchiness from residents that normally would quite easily take their flu vax and what have you, but they seem to be a bit hesitant this year. So what's the general comms that's going out there? Because I haven't really seen a lot. I don't know why, but I must have missed it somewhere. Yeah. But it doesn't seem to be consistent across the system. And also with us stepping up, and I absolutely agree with you about staff welfare and the fact that we need to do the health and safety checks and the risk assessments. Absolutely agree with you. But how are we monitoring this? And those are my questions, because I'm sure there are a lot more out there. Thanks. And thanks.
Great questions, Paul. No, really good sound questions. Rebecca, I'm just going to take Karen Ginsel as well. So if you can hold the answers for that to Karen.
Okay, yeah, thanks, Izzy. And Paulette's just touched on something actually I wanted to mention about the comms. We're particularly seeing difficulty in primary care, accessing primary care, and patients really don't understand around hot and cold sites. and which GPs are not open to patients because of, the circumstances with probably their GPs, and not being able to see COVID positive patients. Therefore, certain surgeries will be closed. So there really does need to be more explanation, I think, to residents as to what's happening in the system. We all know, we get it, but they don't, when they can't go to their local GP and get access, and their telephone systems are causing huge problems. Just it's purely demand. Demand has been built up, and everybody's now coming forward. What I will say is, with the flu vaccine, we've seen some good work on drive-through sites. One of our GP groups, GPS, they did I was down there with them, and they did 2,000 vaccinations over one weekend, a few weekends ago. So that was good, and we need more of that, people getting through. But there is, as Paulette says, a lot of people saying no, don't want the flu vaccine, and they don't want the COVID vaccine because they don't want to be used as guinea pigs, as they state. So it is around the comms that I think we're not putting out properly to our residents, and it's something we've talked about at STP board with the CCGs. We do need to have better communication, and then our residents won't be phoning everywhere and putting extra demand on the system.
Okay. Yeah. Rebecca, some fairly strong questions there. Okay.
So I'm going to take them in turn. I'm going to signpost each one. So Paulette, the Nightingale, at the moment we're looking at the data on a weekly basis in terms of where we might be triggering the need to open it. And I think we've got formally a 3-day timeline that we can stand it up in. We will go to more frequent monitoring if the COVID surge continues in terms of the impact within hospital, and we certainly have daily situation reports that will enable us to do that, and also both the quantitative data but also qualitative, which can be as important in some of these situations as well. So that's the Nightingale. In terms of the flu vaccination, I'm going to just refer to the kind of perhaps the high-level brief in terms of what's going on with the campaigns, but then I'll pick up the specific kind of local issues you've raised as well. So a public-facing campaign was launched on the 22nd of September, and that was closely aligned to the national call and recall system on this. And then there's a Midlands communication campaign, which has also started. And finally, a national marketing campaign starts in early October. I think what you have both highlighted, though, in your comments is some of the local signposting and communication needs to be tightened up. So I'm going to pick that up with our communications lead, our end, and they'll link into the STP comms people, because certainly within everything there is flexibility to make sure that you are adjusting your messages for your citizens, and in particular if there's confusion over the primary care settings that they can be vaccinated in and things, that's got to be very locally designed. So I'll take that away as a point. And then Paulette, you'd also asked about the monitoring of the risk assessment. So I guess formally that would be both at the organisational level, that they would have kind of board responsibility and making sure that they are having the impact that they need to, and some of the data and triangulation around kind of staff complaints, kind of anything to the freedom to speak up Guardian, and those kind of processes actually would give quite a good triangulation if there's significant concerns that they're not delivering the quality of those assessments. But then in addition, across the kind of NHS England and improvement kind of region within the Midlands, we're also doing a bit of an oversight role and trying to get a bit under the skin in terms of understanding that individual organisations are kind of delivering on the so what from those, and that's something that's been kind of monitored within our regional people board, which will also interface to each of the STP's people board.